Welcome to the deep dive. We are really getting into the details today. We're taking these clinical guides, the kind used by professionals at places like the UKPASS Medical Academy, and we're basically turning them into a clear roadmap for cardiovascular decision-making.
Exactly. And our sources are these really intensive protocols. They're designed to teach how to assess, diagnose, and manage everything from, everyday high blood pressure right up to the immediate chaos of a heart attack.
So what's our mission with this?
It's to distill that clinical mindset. We're hunting for the essential triage knowledge, those exact decision points, the numerical thresholds that let a professional instantly tell a minor concern from a true medical emergency.
Okay, so how do you quickly map out that whole high-stakes management pathway?
That's the question.
It feels like a shortcut to understanding the structure of life-saving care.
Yeah.
Okay, let's unpack this. We're starting with the most common and often the most silent threat: hypertension, high blood pressure. Now, when a professional suspects hypertension, they aren't just looking at the number on the cuff, are they?
No, not at all. They're screening, and pretty intensely, for these subtle symptoms that patients they frequently ignore them.
Like what kind of things?
Well, the sources point to these key questions about potential end organ damage. Things like, have you had new headaches? Dizziness? What about blurred vision or even nosebleeds?
Because if the pressure's high enough to cause that, the damage might already be happening.
Exactly. And that screening process is why context is just so critical. Clinicians are looking for red flags that signal real agency.
Okay, so red flags like?
Unexplained slurred speech, maybe some weakness, which could point to a stroke risk. Or, and this is a big one, swollen ankles and legs. That can mean the heart itself is starting to struggle.
And it's fascinating how deep the personal history goes. They ask about your job, right?
Oh, absolutely. They ask specifically about occupation. Does your job involve long hours or shift work? High stress? Are you sitting down all day? Your daily stress is seen as a key part of your risk profile. It's not just some lifestyle footnote.
Which I suppose leads us to the crucial numbers. The diagnosis. In a clinic, the threshold is usually, what, under 140 over 90?
It is, but the sources, and they follow models like the NICE guidelines, they really emphasize using home monitoring.
Oh, to avoid white coat syndrome.
Exactly that. We all know clinic readings can be high just from the stress of being there, so ambulatory or home BP monitoring ABPM is often the preferred way to go.
And when you use those home averages, the threshold actually drops a bit.
It does. It goes down to under 135 over 85. It's a recognition that, your average pressure at home is a much truer picture of your actual risk.
But what if that clinic reading is just dangerously high, like 180 over 120 or more?
Then the whole response shifts. It's immediately into emergency mode. That's a high urgency referral, requires a same-day specialist review.
And especially if there are other signs.
Yes, especially if they see signs of what's called accelerated hypertension, like a retinal hemorrhage that's bleeding in the tiny blood vessels at the back of the eye. It's this very visible sign that the pressure is so high, it's actively damaging fragile vessels all over the body.
Making a stroke or something else just imminent.
It's that serious.
So once hypertension is confirmed, the treatment path is pretty standardized, but it's also tailored to demographics, which I find really interesting.
It is. And the why is the key insight. If you are, say, 55 or older, or if you're of Afro-Caribbean descent, the first drug they'll likely try is a CCB, a calcium channel blocker.
And that's because it helps relax and widen the blood vessels.
Right. The preference is down to known biological differences. Generally, that group often has a better response to CCBs because their hypertension might be less dependent on the body's renin hormone system.
But if you're under 55 or you have diabetes, the first choice is different.
Completely different. It's usually an ACE inhibitor or an ARB. These drugs work by blocking hormones that make blood vessels constrict, so they relax the pipes from the inside, so to speak.
And that demographic split is the primary thing that dictates the first prescription.
It really is.
And they don't give up. If the max dose of that first drug isn't enough, what's next?
Well, the first step is simple. They check compliance. Are you actually taking it correctly?
Right. Makes sense.
Then they'll add a second drug. If that's not enough, a third. It's a very calculated escalation.
And after 3 drugs?
Only if you're still uncontrolled on 3 different types, do they either add a fourth or just immediately seek specialized advice.
Wow, 4 medications. That sounds like a heavy load.
Mm-hmm.
Do the sources talk about the difficulty with compliance with that many drugs plus lifestyle changes?
They do. The lifestyle pillars, salt, Exercise, smoking are totally non-negotiable. They're revisited at these mandatory annual checks.
And those checks aren't just about BP, are they?
No, they also use risk calculators, like QRISK, to decide if a statin should be added to manage your overall cardiovascular risk. So yes, compliance and that constant surveillance, they're central to the whole thing.
That structure of surveillance is such a sharp contrast to our next topic. We're shifting from the silent threat to an immediate crisis. Chest pain.
And the whole dynamic changes. It's no longer monitoring, it's high-speed, high-stakes interrogation.
When you've got acute chest pain, the priority is what? Describing it.
Precisely. Characterizing it. Is the patient describing a crushing feeling? A squeezing? Tightness? Does the pain radiate to the jaw or the arm or the back? What makes it better or worse? That description is the most critical tool they have in those first few minutes.
And they have to rule out other things really fast.
Yep, a rapid process of elimination. Differential diagnosis. You have to quickly rule out things that can mimic heart pain, like, severe acid reflux GERD, or even a musculoskeletal issue.
But the timeline for actual cardiac pain,
Hmm.
that's the trigger.
The recency of the pain dictates everything. If the pain occurred in the last, say, 12 to 72 hours, that patient needs an urgent same-day hospital assessment.
And if it was longer ago?
If the episode was more than 3 days ago, the timeline relaxes a little bit. The follow-up is within 2 weeks.
For patients who already have a diagnosis of stable angina, the sources lay out a very specific 3-step action plan for when the pain hits.
It's designed to be foolproof.
First, stop what you're doing, rest, and take 1 dose of your GTN spray or tablet.
Second, if it hasn't resolved after 5 minutes, take a second dose. Then wait another 5 minutes.
And third, and this is the absolute threshold, if the pain is still there after that second 5-minute wait.
That's when you call emergency services, immediately.
Well,
And chew an aspirin, unless you've been told not to.
Right.
It's a protocol designed to just remove any hesitation when your life is on the line.
and this leads to a fascinating detail. It's where medicine really collides with real life.
Oh, this part is brilliant.
If a patient needs to go to the hospital right now, but they refuse because they're a carer, or, and this is the surprising part, because they have a pet.
The protocol actually guides the clinician on what to do. They are supposed to proactively find a solution. They look for support from family, from neighbors, or even from dedicated charities like the Cinnamon Trust.
I never heard of that.
They specialize in helping the elderly and ill care for their pets during hospital stays.
That's genuinely insightful. It shows that you can't just treat the biology without addressing the social reality that's holding the person back.
It's a key part of the puzzle. Now, moving into post-acute care, after the damage is done, the goal shifts entirely. It's all about robust secondary prevention.
To make sure it never happens again?
Exactly. This is where we get the standard quadruple therapy.
It sounds imposing. What is it?
It is, but it's the cornerstone of long-term recovery after an MI, a heart attack. It has 4 core parts: an ACE inhibitor, or an ARB, a beta blocker, dual antiplatelet therapy, or DAPT, and a high-intensity statin.
Okay, can you break that down for us?
Sure, you're hitting the system from 4 different angles. The ACE inhibitor relaxes the pipes. The beta blocker slows the pump down to protect it from strain. DAPT, which is lifelong aspirin plus another drug like clopidogrel for up to a year, thins the blood to stop clots.
And the statin.
And the high-intensity statin, often 80 milligrams of atorvastatin, stabilizes the cholesterol to prevent more plaque from building up.
And recovery isn't just medical, is it?
Not at all. It's intensely non-medical, too. Every single patient has to be offered comprehensive cardiac rehabilitation. That's physical training, education, and crucial psychosocial support to screen for depression and anxiety.
Which are very common after a heart attack.
Extremely common.
Okay, let's talk about the really practical stuff, driving. A heart attack suddenly intersects with legal requirements through the DVLA, right?
It does. For a Group 1 license, that's cars, motorcycles, you're typically barred from driving for just 1 week, unless there are complications.
Only 1 week, that seems short. But it's stricter for professional drivers.
Dramatically stricter. If you hold a Group 2 license, so you drive buses, coaches, lorries, you are typically restricted for 6 weeks post-MI.
Yeah.
It just highlights this principle we see again and again. Your job directly influences your medical restriction. The public safety liability is just so much higher.
Let's move on to heart failure. This is the long-term consequence when the heart muscle just can't pump efficiently anymore. The red flags here are incredibly specific.
They are, and they signal an immediate emergency. Beyond just general breathlessness, you need to watch for a sudden worsening of breathlessness at rest, fainting, or the very distinct, very worrying symptom of coughing up pink, frothy sputum.
Pink frothy sputum. What is that a sign of?
That foam, that pink fluid. It's a sign that pressure has forced fluid backward out of the blood vessels and into the air sacs of the lungs. It's a state called pulmonary edema.
And for diagnosis, they use specific tools.
Yes. Blood tests looking for elevated levels of BNP or NT-proBNP. These are hormones the heart releases when it's under excessive strain. And then an echocardiogram is essential to actually look at the heart's structure, measure its pumping ability.
Yeah, management.
It's 3 medication pillars: the ACE inhibitors, beta blockers, plus diuretics for the fluid, but also crucially non-medical support. A referral to a specialized multidisciplinary heart failure team is key.
Okay, so let's broaden the scope now. Beyond the heart itself to the major plumbing, vascular conditions, starting with PAD, peripheral arterial disease.
Right. This is basically the arteries in the limbs, usually the legs, getting clogged up.
The classic symptom is intermittent claudication.
It is. It's that pain or cramping that reliably starts when you walk a certain distance and then resolves completely when you rest.
So the assessment is all about pinpointing that distance.
Exactly. That distance and the time it takes for rest to make the pain go away. The management hierarchy here is non-negotiable. First, you have to stop smoking, period. Then supervised exercise.
And only after that do they move to drugs.
Only after those 2 lifestyle things are established. Then they bring in a statin and an antiplatelet drug, clopidogrel. But exercise is really the gold standard here.
And if that fails?
If supervised exercise fails, then the clinician decides. Either a referral for a procedure like angioplasty to widen the vessel, or moving to a specific drug like naftogyrfuryl oxalate. It's very, very systematic.
And what about the other major silent vascular risk? The abdominal aortic aneurysm or AAA?
This one is all about surveillance. It's a bulge in the main artery in the abdomen. They screen men over 65 for it routinely.
And the size is the critical factor.
Size is everything. If the aneurysm gets to 5.5 centimeters, that triggers an urgent 2-week referral to a vascular specialist. The risk of rupture just goes way up at that point.
And the DVLA rules come back into play here, don't they? And they're different based on your license.
Massively different. For a personal car license, Group 1, you only have to inform the DVLA and stop driving if the aneurysm gets to a huge 6.5 centimeters.
But for a professional Group 2 license,
the bar is way stricter. You have to tell the DVLA at any size, and you have to stop driving if it reaches just 5.5 centimeters.
that 1 centimeter difference really illustrates the seriousness of that public safety liability.
Absolutely.
Okay, let's wrap up our deep dive with the electrical system. Rhythm issues, which often show up as palpitations.
Right. And the assessment is all about the description. Is the feeling regular or irregular? How long does it last? How often? And crucially, were there any red flags at the same time? Chest pain, dizziness, fainting? Did it start during exercise?
So triage is everything.
It determines the entire pathway. Mild symptoms, often managed with anxiety support. But if you have any of those red flags, chest pain, dizziness, a family history of sudden death, that's an urgent cardiology referral.
And if the palpitations are happening right now?
Continuous palpitations right now, that's an immediate same-day hospital admission.
What about specific arrhythmias, like a slow heart rate?
Bradycardia. If the heart rate is below 40 beats per minute and you're feeling symptoms, you need to be in the hospital. If you're asymptomatic, you still need a cardiology referral to think about a potential pacemaker.
And for atrial fibrillation, or AF, timing is the key decision point.
It's critical. If the AF started less than 48 hours ago, the protocol leans toward hospitalization for cardioversion defibrillation to try and shock the heart back into a normal rhythm.
And if it's been longer than 48 hours?
Then the focus shifts entirely to long-term management, using risk scores like CHADE-VASI to guide anticoagulation, often with a DOAC like apixaban, and then using drugs like bisoprolol for rate control.
We've covered a huge amount of ground here: chronic management, acute crisis, long-term recovery, all across the cardiovascular system. What really stands out from these sources is how a single symptom can just open up this massive, complex, but really structured pathway.
It really does. And this material, it just underscores how specific everything is, whether it's knowing your family history or recognizing that the damage high pressure does to small vessels. You see it in your eyes and your feet.
So what does this all mean? We've seen that these protocols don't exist in a vacuum. These sources reveal that a major health event, a heart attack and AAA diagnosis, it doesn't just change your body chemistry. It directly intersects with civil duties,
Mm,
with legal requirements.
mm. And that brings up a really important question for you to think about. How does modern medicine balance this stringent biological risk assessment with its focus on millimeters of vessel size or milligrams of drug dose, with the practical, social, and legal responsibilities that define a patient's daily life?
Things like who is responsible for caring for their pets during an emergency, or whether they're legally allowed to drive a heavy goods vehicle for their livelihood.
Exactly.
A truly fascinating intersection of health, policy, and human responsibility. Thank you for joining us for this deep dive into the cardiovascular compass. We'll see you next time.